there's a lot more than you think out there. And then we get into the mundane side of things, which is the colon cancer risk, cholangiocarcinoma risk, and I don't want to dwell on that too much today, because honestly we don't understand enough about it yet. Few big concepts. If you can see it on ERCP or MRCP, it's large duct disease, and if you can't see it on that, but on a liver biopsy, it's small duct disease. And that matters both for what's going to happen to that patient in their lifetime, but also which patients are being recruited into clinical trials. And the reason for that is, if you've got small duct disease, that's the top line, your rate of conversion to large duct disease and end-stage liver disease is incredibly low. So that's a very good disease to have. Some people will convert, and most of the ones converting will have very active IBD, which really raises some points about IBD care in these patients. But then once again, if you've got large duct disease, through time, you will deteriorate, getting to end-stage liver disease and requiring transplantation. And if you're then unfortunate enough to develop dominant extrahepatic stenosis in your bile ducts, you're at even higher risk of coming to end-stage liver disease. So it's important to get the nomenclature right, and that's also what's getting recruited into clinical trials, is predominantly large duct disease. That's the high-risk one. So there's a bit of lag on this one. The difficulty for me going to pharma companies has been, how do we know a drug's going to work? So if a pharma company is going to do a phase 2, phase 3 study, what's the endpoints? How is this going to work? And honestly, a lot of things are not feasible in PSC. So if you say time to end-stage liver disease, that's too long. That's a gold standard, but nobody's going to wait that long to do a 15-year study. It's just not going to work. Liver biopsy for lots of diseases, the FDA has always insisted on liver biopsies. It's impractical. The other thing that is looking at fibrosis, and most people now have FibroScan and do FibroScan, and you can use FibroScan in a variety of different ways. You can look at absolute baseline levels and see what happens to that. So if you have a FibroScan of 9.9 kilopascals, generally deterioration through time is low, whereas if it's higher, you've got more attrition to get into transplantation. Or you can look at delta changes. So this is a delta change of 2.5 kilopascals, and it separates out progression in disease, so that's a change through time. And you can refine that even to 1.3 kilopascals. So you can look at fibrosis as an assessment, and you can do that non-invasively. And this really all builds into the next form, and I don't know if you've got access to that, and it's MRI-based elastography. The problem with FibroScan is you're doing a measurement of the right lobe, and it's a very limited area you look at. If you do MRI elastography, you can add it in with the annual MRCP that you're doing in your patients anyway, and you can map out the liver. And what you're seeing here is you see geographic variation in stiffness in the liver. So there's different ways of getting an overall global assessment of fibrosis. And actually, if we just look at baseline fibrosis, it performs way better than any of the other scoring systems for predicting varices and end-stage disease. So alkaline phosphatase, pretty pointless, but we will include it in the studies, and if nobody has any itch, then so be it. It's not going to be important. And most drugs for the FDA will go through accelerated pathways. What that means is it's a fast track through, but there will be an obligation to do phase 4 studies at the end to show long-term safety. So at least we've got consensus about this with the regulators. If I did this talk for you 5 years ago, there was almost nothing we could do for PSC. This is where the map for PSC stands now as far as products go. And I sort of split them into a variety of different ways to think about how to address this. The one thing that clearly is important is the microbiome. Sepsis is part of a lot of PSC patients, and there's been a lot of work around metronidazole, vancomycin, and there's people who do their fecal microbial trans-C, and I'm embedded in a very good IBD unit. And for quite some time, we're high users of biologics in the unit, and the reason for that is we go after mucosal healing. We don't go for symptomatic remission. And if you look at the PSC patients, now this is PSC patients that are receiving either infliximab or adalimumab primarily for their IBD. We're not using it off-label for PSC, we're looking after their IBD. The ones that saw a normalization or 50% reduction in their alkaline phosphatase had a few unique features. It really didn't matter how much IBD you had. So whether you've got mild IBD, moderate IBD, highly symptomatic, non-symptomatic, it doesn't matter. The people who respond are the ones with very inflamed livers. They do respond really well. The small duct PSC responds extremely well. And I think this is the way you can stop the disease in its onset, is at the small duct version. But really the big thing is here, if you achieve histological remission. So if you have an IBD PSC patient, you treat them with a 5-ASA, they have no symptoms, you scope them, they still got mild to moderate right-sided disease. That is probably too much inflammation for a PSC case. You really have to go after that. And if you go after that, quite often they drop the alkaline phosphatase and normalize it. And so I think these are things to go to the different targets. And for some of you who live in the IBD world as well, you'll be told you have to get mucosal healing. That's your target. That's your treated target. So it really changes your targets that you go for on this. And similarly, we have over 40 patients on vedolizumab with coexisting PSC in Calgary, and you'll see similar things. You'll see some people with great responses in alkaline phosphatase and others with no responses. This is short-term data. We've only had vedolizumab for about a year. FibroScan is not that helpful in short-term data. You see a few drop, but not a huge amount. So I don't think it's whether it's a TNF or vedolizumab that's specifically happening in the liver. It's all about what happens in the GI tract. Now, these are just a little bit north of here. If you go up to Borneo and do some traveling there, it's absolutely marvelous. These guys are really cute when you actually see them in their nature environment. And Borneo is quite famous because, you know, some people were digging around in the soil in Borneo and discovered vancomycin. This is where it comes from. They were trying to isolate some novel things out of the rainforest, found vancomycin. We use vancomycin a lot. And vancomycin has been a real pain in PSC because of this study. This study has created chaos for anybody with a big PSC practice. Keith Linder ran this study. Keith is a good friend of mine, and he gets battered about the stability. We've defined a whole bunch of PSC susceptibility genes, and we've just got another Nature Genetics paper now that shows that PSC IBD is a very unique disease genetically. So we've done but there's lots of heterogeneity, lots of genes in there. And it's shared with other autoimmune diseases. Here's PSC, and there's all these other autoimmune diseases, and you can draw these maps of shared diseases. And so you have patients not just with PSC, they have other autoimmune diseases, but within PSC there's multiple genes as well. So it's very heterogeneous. It's not everybody is the same. And if you've got PSC patients in your practice, no two PSC patients look the same. And so one of the variants we found for PSC is the FIT2 variant. This is a secreted protein on your epithelial surfaces. This is the thing that cleaves your protein so that your blood group is detectable on a mouth swab. And FIT2 variants, when we looked at what happens in the bile of FIT2 variants, they have altered microbiome. And it's not important to know which species are up or down. It's just their microbiome is different. So it tells you maybe that in some patients with FIT2, and FIT2 is about 10% of the PSC patients, they have a different microbiome potentially. And so we did a very early study in Calgary where we looked at, okay, if we're going to give somebody vancomycin, this is the way to go here, because honestly, we start off with very low VRE. After 12 weeks, almost every single patient is VRE positive. So this is a no-go. And actually the effects of vancomycin start to tail off after that period. So I don't think this is the cure-all, but it demonstrates some concepts about PSC. These are African baboons. They are really quite cool, very close to humans, very sweet. And the nice thing is in Africa, they have a varied diet. They eat lots of wild things, grasshoppers, everything else. They don't get PSC. You take them to a zoo in Texas where people give them French fries and candy and burgers and all sorts of things get flicked at them. This is the histology of baboons in the zoos in Texas. This is the closest you'll get to PSC in animals. And this looks exactly like the concentric fibrosis you'll see in PSC. And you know, this is a picture on the side here of PSC from one of my patients with the concentric fibrosis. It looks identical. So diet matters. Westernized diet matters. How it does this, we don't know yet. But certainly I think we'll learn more about the diet as we move forward. And for most diseases with PSC, so those are low-level IgG4 levels with proper PSC. And then there's high levels of IgG4, which isn't PSC, but it looks like PSC. And these are two very different concepts. This is a young guy of mine, 26-year-old. This is his cholangiogram, lots of strictures and dilatations in here. He came to me with used CMPSC for 7 years. 10% of their PSCs have got increased IgG4 levels, but they're usually male sex. They usually have a history of pancreatitis. They have a very high rate of biliary interventions because this seems to pick out a subtype of PSC with more extrahepatic disease, so more CBD, common hepatic duct disease. They usually have abnormal pancreatic imaging or chronic pancreatitis, higher alkaline phosphatase levels, and there's a suggestion that they might have higher risk scores for Mayo. And that's sort of borne out of another study. Not really enough to call this a true autoimmune hepatitis, but one of the features that you'll find with these highly inflamed IgG4 high diseases is that some of them are steroid responsive. And it's worthwhile giving some of these a trial of immunosuppression. And we do the same as the previous talk, where we start prednisone first, tail it off, and then bring in Imuran later. And actually these numbers dropped very well. So within that high IgG4 range, it's probably a more aggressive disease, and some are steroid responsive. And whether this makes any difference to the outcome of this patient, we just don't know. This is such a new concept, a new disease, we just don't know. But it's worthwhile addressing these guys because they're at higher risk of progressing. And so I think, we call it different things. Non-traditional autoimmune hepatitis, you'll go to other places. Steroid responsive PSC, you'll go pericholangitis. There's so many, the nomenclature is so wide around this. But look for these cases. They're often younger men that have this. Then we get to, but if you biopsy them, you find a few key features. You find a lymphoplasmacytic infiltrate. A key feature of IgG4 disease is fibrosis. There's a lot of interstitial fibrosis in there. And if they do IgG4 staining, you can pick up IgG4 positive cells in there. So biopsying these masses are really worthwhile doing. Whether you do it with endoscopic ultrasound or percutaneously, you pick up IgG4 disease. And this is generally what happens. So this is this guy's IgG4 subclasses at the start of it. And if you immunosuppress them, it drops down beautifully. Now there's a few rules about how you treat true IgG4 disease. And it's because it sits on a spectrum of responses. Most of the time, if they don't have big pseudotumor masses, so if it's just purely inflammatory, it looks like PSC, but they've got a IgG4 of 9 or 10, they're going to respond similar to autoimmune hepatitis. It's going to be prednisone, azathioprine, mycophenolate. It's a very similar response. Once they get to having big pseudotumors, the vast majority are steroid resistant, need multiple courses of steroids, and the biggest mistake we find with all these cases is they get soaked in steroids. So now you have relatively elderly people soaked in steroids, which is a disaster. Get in there with rituximab. It works beautifully well. 2 doses, 2 weeks apart, 1,000 milligrams, super safe even in the elderly, and those masses fade away within a month. It is a very safe drug. So our practice has been, I will start somebody, first of all, I'll give them 1 course of steroids. After that, if they don't have a great response, they're on to rituximab and they all respond. We have in Calgary an experience of rituximab now, and probably close to 100 patients with either autoimmune hepatitis or IgG4 disease. Once you start using it, you'll love it. It's such a clean drug. But we had to beg a lot to get access to the drug and get the funding sorted out for it. But certainly for pseudotumors, you have to go down this way. And I think the way to think about IgG4 disease, it's a disease that starts off inflammatory. You get a lot of plasma cells initially, but once you get to pseudotumors, it's almost as if you're going into a malignancy. It's almost thinking about a multoma that starts off inflammatory, infectious, and becomes more of a malignancy eventually, where you have to bring in rituximab. And that's one of the ways probably to think about this disease. The key thing, a lot of these patients have very significant pancreatic disease, and they're very malnourished. So you have to feed them well. A lot of them are a big discrepancy in that. This is looking more about IgG4 disease. What do these patients actually look like? In Oxford, this is Roger Chapman's data in Oxford. Out of 105 cases in Oxford, we'll have PSC biliary changes. And then if you look down here, if you look at the prevalence here, there's a lot of pancreatic disease. They have disease elsewhere as well. So quite often they can get lung disease, they can get swollen salivary glands as well. You can get renal fibrosis. So there's a spectrum. It's a systemic disease. What these patients don't have a lot on, and look at the bar down here, this is 2%, 4%. They don't have a lot of IBD. Okay, that really distinguishes them away from your typical PSC patient. They don't have a lot of these other autoimmune diseases that we commonly associate with our PSC cohorts, alopecia, vitiligo, arthropathies, and thyroid disease. So they look different. And just getting close to wrapping this up, Ulrich Beers in Amsterdam has actually gone on a mission on collecting as many IgG4 patients as he can. And the way how Holland is structured healthcare there is it's actually possible to probably capture every single one within the country. And we've talked about how do you diagnose IgG4 disease. Most people will say, okay, IgG4 levels 4 times or 3 times the upper limit of normal is a good way to try and pick it up. The only catch to that is the more of a pseudotumor you get, the more your IgG4 levels drop and the more reliant you are on histology. So just because it's twice normal and is a big pseudotumor does not mean it's not IgG4 disease. You have to biopsy it. And I think, once again, think about lymphomas and things like that. They actually start dropping their light chains and things the more. So think about it as a malignancy in one way. You can do a ratio between IgG4 and IgG1. That's a potential way to think about this as well and work it out. Blood IgG4 mRNA levels are highly diagnostic. And we're all begging our labs to start doing this. This really helps. The other interesting thing, and certainly this is what we're seeing in Calgary as well, in Caucasians, and I'm not talking about the Southeast Asian cohort because it seems to be a real group susceptibility there. In Caucasians, it's often blue-collar workers. It's painters, people who work in painting factories, solvent exposure. So there's something environmentally I think we'll learn eventually about IgG4 in this. And so I think when I started off, we had one disease, PSC. We tried to make some changes within PSC. Now it's really complex, and we know even less than we did before. You know, we have large duct, but with variants in there, with progressive disease, recurrent cholangitis, juvenile onset versus mature onset. We have small duct versions. We have IBD with or without PSC. We have these things, which is a different talk altogether, because we really have not made any headway there. And then we have the overlaps and all the IgG4 interaction of that. And so this is Calgary. You should all come and visit. It's lovely because you can go for a run here in the afternoon and be skiing up there in the evening. And so the only downside is at times it can be minus 35 degrees Celsius. But thank you for your attention. Nope. So it's the one split globally. So in the EASL guide. We do an awful lot of that. So a few things around that. I think there's no justification. If you start getting pains and fevers, you start taking it. And you self-treat you and you avoid a lot of admissions doing it that way. Then what will happen is most never use it. Some will use it occasionally once a year. But my rule is if you have 3 attacks in 6 months, usually if you look at what happens to the inflammatory parameters in those patients, they stay up. So I'm worried about them. Then I'll put them onto rotating antibiotics. And I tend to rotate them usually every 2 weeks between 3 antibiotics. And so the mainstays are usually a fluoroquinolone, so ciprofloxacin. We might put in some Bactrim in there, and Cefixime is a 4th generation cephalosporin, which is once a day. We tend to put that in there, but so we rotate them through that, and we don't see too many issues because we're largely staying away from the penicillins. We don't see too much C. diff and other complications to that, which for the IBD patients particularly is an issue. So I tend to rotate between that sort of ranges of it, and it works well. Before I moved to Calgary, I worked in Birmingham, and James Newberger generated some really good data to show that in the cohort in Birmingham, if you did a colectomy pre-transplant, you had almost no recurrence of PSC post-transplant. And the problem with that data is that the vast majority of that data was generated at a time when we didn't have biologics for IBD care. And so I think what you can achieve with some of the modern IBD drugs is almost a chemical colectomy in some of these patients. So I mean, I think if you can take somebody's colon and you put them into histological remission, mucosal healing, you've achieved the same as doing a colectomy. So that's sort of my approach is I think we're doing a colectomy but in a different way. The one thing that I never want to see happen in my patients, particularly in the younger patient group, if they are failing IBD meds, so they still got an inflamed colon and they've got progressive PSC, I don't ever want to see them going into a transplant with a red hot colon. That's because all the predictors of recurrent disease is active IBD going through your transplant. So those are the ones where I might push a bit harder to say, we've burned through all the TNFs, integrin inhibitors, ustekinumab, everything, and we don't have any treatment options. I'd rather, we think about a colectomy in your case before you go into a transplant. But that's about the only time. But I think the data, you need to look at the timing from when the TNFs and the other drugs were being used.
Thank you. So it's good to be here. I've done something new today. I stole a suitcase on the way here by mistake, so I had to take it back to the airport. Never done that before. It's always good to do something new, I think. So I just want to acknowledge, I see Jeff Farrell's here in the audience, and in fact, Jeff has published a lot in this field of drug-induced autoimmune drug-induced liver injury. So I want to acknowledge his expertise. I've got no disclosures related to this, although all related to hepatitis C. So just to start with definitions really, so drug-induced liver injury is any injury to the liver by a prescribed medication, an over-the-counter medication, a herbal or dietary supplement that can manifest as a spectrum from very mild asymptomatic liver function test abnormalities through to acute liver failure. So it's a very heterogeneous group. It is said to be a rare clinical event, but it carries significant morbidity and mortality. So that's why it's important. And of course, we're all aware that almost all therapeutic drugs have a mixture of benefit and harm or toxicity. So it's always a matter of balancing these things in medicine. If we just begin by looking at some of the more recent epidemiology sort of emerging in the field of drug-induced liver injury, or DILI as it's called. The annual incidence in some recent studies is between 14 and 19 cases per 100,000. So that means for the average New Zealand city, we should be seeing quite a few cases per year. But of course, some of those are just managed at the GP level or by the rheumatologist, for example, who might just stop the medication. And as a specialty group, we tend to get involved more with the more severe cases. The Drug-Induced Liver Injury Network from the US have done some good prospective work and are gradually accumulating a large volume of cases. So we're starting to get some useful data out of that. And they recently published on 900 cases of DILI. They showed that the mean age was 49, 59% were female, and importantly, 10% of all cases either died or underwent liver transplantation. So 10% had those severe outcomes, and 17% went on to develop a chronic liver injury. So I think this is why DILI is important. There's a very mild spectrum that can be easily dealt with, but there's a severe spectrum that's major morbidity and mortality. Also along the field of epidemiology really, and out of the same group's work, we see what the top sort of 10 drug classes and the top 10 drugs are that are implicated in drug-induced liver injury. And so I just want to highlight that the top 2 therapeutic groups are antimicrobials and herbal and dietary supplements. And of course, half the time the patients don't tell us they're taking those. I got caught out this week with someone who had said, no, and then when I asked the question about the 4th time, and over 3 months, she finally told me about the 5 supplements she's taking. So, really important to get that history right. If we look at individual drugs, many of these are familiar to you. Amoxicillin, clavulanate, or Augmentin is still number 1, along with isoniazid. Nitrofurantoin, cotrimoxazole, and minocycline are fairly well known. Other ones that are emerging a bit more, cafezolin, azithromycin, ciprofloxacin, levofloxacin, and diclofenac. So they make up the top 10, according to this big cohort of 900 patients. It's very important from a sort of public health perspective too, because of course, when we look at cases of acute liver failure in a Western country, drug-induced liver injury accounts for more than half of cases. So in the US acute liver failure study group, 45% of their acute liver failures are related to acetaminophen, or paracetamol as we call it. Another 11% were related to idiosyncratic drug liver injury. So that makes up 66% of all acute liver failure. It's different in Asian countries where viral hepatitis and other things are more dominant causes. But in the West, like us, it is a major cause. And in the context of acute liver failure, again, isoniazid features heavily, cotrimoxazole, antifungals, anticonvulsants, and again, herbal drugs feature strongly. The challenge, of course, with DILI is that it basically can mimic any type of liver injury. Any of the scenarios we see, from sinusoidal obstructive syndrome to sort of bland cholestasis to, a sort of viral hepatitis-like phenotype, any of those things can be mimicked by drug-induced reaction. And so I think we have to have our radar out and be very aware of the potential that a drug cause could be underlying a liver presentation. So I just want to spend a couple of minutes looking at different ways of classifying drug-induced liver injury. So first, one that is most commonly used is separating out intrinsic or predictable drug reactions, such as paracetamol, from the idiosyncratic reactions. So the intrinsic or predictable ones, such as paracetamol, usually have a rapid onset or a short latency period from when the drug is taken to when they get the liver injury. They're dose dependent, and all of us are probably well familiar with this, of paracetamol nomograms, where we know if a patient has a particular dose of the drug at a particular time and you have a blood test at a certain time point afterwards, you can then calculate what their risk is of liver toxicity. Unfortunately, the idiosyncratic ones are much more unpredictable. They have a longer, more variable latency, they're less common, and they are independent of the sort of dosing regimen. They just occur at random in a few unlucky individuals. And I see this as more akin to winning the lottery in a sort of negative fashion. Although you're probably more likely to get this than to win the lottery. So idiosyncratic drug reactions are one that we spend quite a lot of time looking at and trying to work out risk factors for, and why do some people get them and not others. Other ways of classifying DILI, when a patient first presents, the usual thing is to classify them by the pattern of liver test abnormality. And there are all these sort of calculations you can do at R-score and things to work this out, but I think most people in this room would be able to look at a set of liver tests and say that's basically a hepatocellular pattern, or a cholestatic pattern, or a mixed pattern. So about half of liver drug reactions are hepatocellular. Common drug groups implicated in that, and these are not exhaustive, they're just sort of common ones, are analgesics, so paracetamol, aspirin, Ray's syndrome in children used to be described quite often, NSAIDs, antimicrobials, so again the antituberculous medications, tetracyclines, antifungals, ciprofloxacin, antiretrovirals and things. And also a range of cardiovascular medications, just highlight there, amiodarone, lisinopril, losartan, statins, and some of the rheumatological things. So there's a wide group of things, but some of them you can group in classes. When we look at cholestasis, it's a smaller group, although there are, of course, other drugs other than those listed here, but generally we're probably more familiar with the common antibiotics, Augmentin, flucloxacillin, erythromycin, antipsychotics, and sort of anabolic steroid or oral contraceptive estrogen-related drugs. And then, of course, with mixed reactions, a huge range of drugs that can be implicated. And herbal drugs can cause all these patterns. The other thing that's very important clinically is to establish whether a person has a clinical sort of immunological or immune phenotype or not. And by this, I'm talking about a true sort of allergic hypersensitivity reaction. So the immune-related DILI typically occurs within 6 weeks of drug initiation, so it comes on reasonably quickly. And it's important to identify these because if you accidentally or intentionally re-challenge these people, they have a high risk of a significant re-injury if you re-challenge them. You shouldn't do it. Particularly important to note if they have any of the severe cutaneous features. These are rare, only 1%, but if you do have things like Stevens-Johnson or toxic epidermal necrolysis, they have a mortality of 40% if they have liver involvement as well. So that group is a very high mortality group. You should identify that early on. Of course, a lot of them will have more mild features of this sort of immune phenotype with some autoantibodies, a bit of rash, a bit of fever, eosinophil count. I've done it to a few people with azathioprine myself. So it's worth noting those. In contrast, the non-immune DILI tends to be a sort of slow onset, longer latency period, and they lack those systemic features. So it's often asymptomatic, just abnormal liver function tests picked up unless they present late. And these ones don't have such a dramatic phenotype if you re-challenge them. Causality is always challenging because drug-induced liver injury still remains as essentially a diagnosis of exclusion. There's no box you can tick on the blood form that will give you a diagnosis. Patients often take multiple drugs. They don't always tell you what drugs they're taking or know what drugs they're taking. And there are confounders, as with a lot of things in medicine. So now when they've reanalyzed some of these databases and looked back at months of drug exposure with a drug-induced liver injury, there are some drugs that present much later. So, and some of them have a latency of up to 12 months. And so particular drugs associated with this are nitrofurantoin and minocycline, and also 6-mercaptopurine statins are increasingly being recognised in this group, and also amiodarone. So often as clinicians we look at the drug chart and go, oh, we don't need to worry about them, they've been on those drugs for ages, they won't be the cause of the current problem. But in fact, we need to be aware that these drugs may still be the cause even if they've been on them for quite a long time. Of course, there are many risk factors, and of course, when you don't fully understand why an individual gets the thing, you look at lots of different risk factors and how it all interplays to establish why some people get this and other people don't. You know, why do some people win this lottery compared with others? So various features we look at are things like drug properties, host factors, genetic factors, metabolic factors, immunological factors. And I'm going to go over a few of those, not in too much detail, but just to sort of see the big picture. So, of course, the liver metabolizes drugs, and this is why the liver is vulnerable to toxicity from drugs and metabolized. It's interesting that although with idiosyncratic reactions we say that it's not dose related per se, there is actually a dose threshold effect that's been observed over the last couple of years. So in fact, if doses are drugs are dosed at a higher average daily dose of 50 to 100 milligrams or higher, then they are more likely to cause liver toxicity than drugs that are usually dosed at, say, 2 or 5 milligram per dose per day. We also know that drugs that affect biliary transporters can predispose to some injury. For example, the BSEP transporter transports bile acids, and so if a drug inhibits the BSEP transporter, you get bile acid. You can get bile acid accumulation and liver toxicity from that. And some drugs such as triglyceridone or ketoconazole are in this category. They are BSEP inhibitors. They do have a liver safety signal with them. There's been a lot of work too in the last couple of years looking at the mitochondria and mitochondrial toxicity from drugs. And this is important because, of course, the mitochondria are the cellular energy supplier to the hepatocyte, and if they're damaged, they trigger apoptosis and necrosis. So I won't grill you on this slide afterwards, but just to show, really some of the work that's happening, looking at mitochondrial toxin-mediated reactions tend to be slower with a longer latency because it takes time to accumulate the drug. The other thing, though, that's been recognised over the last probably 5 or 10 years is that some of the liver drug reactions that don't appear, and you then get a sort of aseptic immune response, which leads to liver injury in these people. So there is an immunological component even to the liver drug reactions that don't appear overtly immunological. And we see this when we look at genetic factors. There are HLA associations with drugs like Augmentin and Abacavir and flucloxacillin. And so these drug reactions probably are immunologically mediated in these people. We look at other genetics, we see that variants of some of the other drug metabolizing enzymes such as the UGT2B7 and the CYP P450 enzymes also confer risks, and also if you've got mutations in BCEP and MDR3 drug transporters, you're more likely to get cholestatic drug reactions. So we're gradually understanding a bit more about the genetic background of people and what's going on. There are a few other sort of general host factors we look at, age and gender, and we used to think it was all sort of more likely if you're an older woman. Some of that's a little bit more in question now because, of course, older people take more drugs anyway, a lot of confounding factors. What is clear is that people over the age of 60 are more likely to get cholestatic liver reactions, and that women are overrepresented in the groups with hepatocellular injury and acute liver failure. We do know that some other lifestyle factors have an impact, so alcohol does increase your risk of toxicity from multiple supratherapeutic paracetamol doses, and also probably increases your risk of fibrosis with methotrexate. Of course, with the population expanding, NAFLD becomes an issue, and so there's probably some synergy between risks of NAFLD and things such as methotrexate toxicity, corticosteroid-related NAFLD, etc. One question that always comes up clinically is people get worried about people with cirrhosis and can I give them flucloxacillin or not, because if they might get a liver reaction and that might be a bad idea. And so this is always a question that comes up, I think, clinically. Hy Zimmerman many decades ago said that most drugs can be taken safely by patients with chronic liver disease, but if they get a DILI, then the outcome may be more severe. And this has been validated recently with the US cohort showing a threefold increase in mortality if a person with chronic liver disease does get a liver drug reaction. But in general, their risks of doing so are not higher than anyone else. A couple of exceptions there. One is that there's an emerging signal that perhaps azithromycin is causing more reactions in people with chronic liver disease, and some conflicting data around hepatitis B and C co-infection and the risk of reactions to antituberculous and antiretroviral medications. When we look at prognosis, the big thing that's always quoted is Hy's law. Hy Zimmerman was a hepatologist back in the 70s, who basically stated that when drug-induced liver injury causes sufficient hepatocyte injury to affect global liver function, and in particular to cause jaundice because of impaired bilirubin transport by the liver, then the hepatotoxicity is likely to lead to patient death. And this is always quoted in various forms, and it's often rephrased, etc. The FDA, though, have basically taken sort of a version of this and interpreted it that if the ALT is greater than threefold elevation and the bilirubin is more than double in a hepatocellular type pattern, that's not a cholestatic reaction, but in a hepatocellular one, and there's no other cause, then that is a serious sign of risk of mortality, and certainly has been invoked to cause discontinuation of some drugs. It's been validated in some drugs such as isoniazid and halothane, etc. So the regulators still do pay a lot of attention to that. One of the other things that's emerged more recently in terms of prognosis and outlook is that, in fact, although we expect that most patients will improve when you stop their culprit drug, there is this percentage of 17 or 18% of people that actually will go on and get a chronic liver injury. So they do need to be followed up to ensure that, see if their liver injury resolves. If a person has an initial cholestatic presentation, they are more likely to get a chronic liver injury. And if they have a more severe initial liver injury, they're also more likely to get chronicity. If the liver test is still abnormal at 6 months, then 75% will still be abnormal at a year. And of course, we do know that some people go on and get long-term chronic liver disease with things such as vanishing bile duct syndrome. So it's important to just be aware of that. One thing I just wanted to spend a couple of slides talking about, because it's being increasingly recognised as drug-induced autoimmune hepatitis, and it's quite timely this flows on from Rachel's talk. Similar to autoimmune hepatitis, really, there's a female preponderance, and both women and people who are of older age will get a more severe version of this if they get it. Drug-induced autoimmune hepatitis has a latency of anything from 2 to 12 months. And I've put a list of the main corporate drugs. So some of these are well known to us. I think most of us are probably aware that minocycline, nitrofurantoin, and alpha-methyl-dopa are sort of well known to cause this. But fibrates and hydralazine can also. And the two that are new that I think I draw to your attention is statins, and there's sort of increasing literature around statins as a cause of drug-induced autoimmune hepatitis, and also the anti-TNF alpha drugs. So infliximab, etanercept, adalimumab do cause liver test abnormalities in about 6% of people, and a proportion of them will get moderate to severe autoimmune hepatitis, complete with autoantibodies. So clinical features of drug-induced autoimmune hepatitis are actually very similar to idiopathic autoimmune hepatitis. So they get the same autoantibodies, they get the high IgG, they get a hepatocellular pattern of liver test abnormality, and a small percentage get some hypersensitivity features. I guess the thing that's a wee bit different is the management. So the initial management is to withdraw the drug. Some will resolve just with drug withdrawal, so you don't have to rush into treatment. If they don't recover, and if they do recover, it's over 8 to 10 weeks. If they don't recover quickly, then you can add steroids, and 90% will respond to steroids. Where this differs from the idiopathic autoimmune hepatitis is that you actually can withdraw steroids after 6 to 12 months, and they have a much lower relapse rate than the idiopathic autoimmune hepatitis group. So this is the group that I'm always a bit more optimistic about actually withdrawing immunosuppression in. The one exception to that appears to be the statin-induced autoimmune group, and there does seem to be a bit more literature around them needing either MMF or thiopurines afterwards. The autoantibodies are a bit slow to resolve, so they will lag behind the liver improvement. Just a couple of other things to highlight before I finish. A couple of other antimicrobials that have come into a bit more prominence recently. Azithromycin, there are a number of cases of this, and also cafezolin, causing a hepatocellular type DILI after a latency of 1 to 3 weeks. Some of them can be mild, but there have been some severe cases with both these antibiotics. And I would draw your attention to the fact that some of the reports with cafezolin have been after just a single dose. So I've sometimes tended to discount just a single dose or something, but it is significant. Fluoroquinolones tend to cause more of an immunological type pattern with the sort of hypersensitivity features. Finally, herbal drugs. I wrote a review on this about 15 years ago, and it remains a major cause of drug-induced liver injury. So about 30 to 40% of our patients will be taking herbal drugs or supplements. They may or may not tell us. And about 16% of all DILI is related to herbal drugs or supplements. There are some particular challenges. Patients don't always disclose them. They take multiple versions of these. They have multiple components. Some of the components aren't even labelled. They're not under any regulatory control, and they can be contaminated with things that they aren't even meant to be in there. And of course, they are far more pharmacologically active than people realise, so they can cause drug-drug interactions, but they can cause toxicity as well. So just obviously a full review is beyond the scope of this, but a couple of recent trends are for bodybuilding supplements in men being associated with prolonged jaundice, and yet again, cases of acute hepatitis or acute liver failure related to a fat burner called Oxy Elite Pro. Quite a few cases of that recently. What do we do for treatment? So the key mainstay of treatment of DILI, of course, is drug withdrawal. Tip the pills down out of the bottle. Stop the offending drug, and expect that the majority of people will improve. The subset that I think steroids have a role for are the drug-induced autoimmune hepatitis. So if they're autoantibody positive, got high IgG, that's a group that you may consider using steroids, and also perhaps some of the people with hypersensitivity reactions. N-acetylcysteine is a mainstay of paracetamol, liver toxicity, and a bit more controversial in non-paracetamol acute liver failure. Early studies did show NAC improved transplant-free outcomes and survival in people with early coma, but not people with advanced coma. But I think most units do tend to use it. Ursodeoxycholic acid is a bit more controversial, probably is used in people with more severe cholestasis, but the data for that is more sort of anecdotal case reports, case series. And carnitine can be used for DILI-induced by valproate. So just to summarise, drug-induced liver injury is a rare clinical event, but it does cause significant morbidity and mortality. It's very important we recognise it when it does occur. A wide range of drugs are implicated, including herbal medications, and I think there's increasing recognition of this drug-induced autoimmune hepatitis phenotype that we need to be alert for, because that's a group we may actually be able to stop immunosuppression in. And just emphasise the importance of thorough drug history. Thank you.
Hepatitis. I'm not convinced I've ever seen any liver fibrosis attributable to methotrexate. I've never seen any cases where they haven't had massive risk factors for fatty liver disease or alcoholic liver disease. I'd be interested in your experience. And then,
we've had one Christchurch patient transplanted recently for methotrexate.
For a standard rheumatological sort of dose?
I think so.
And no metabolic risk factors?
Well, I only met him in his late. I mean, he's not my patient, but didn't look particularly fat from the end of the bed. We've had the odd. I think we have had other ones over the years who've had decompensated disease, but often, as you say, often fatty liver as well. So I think it's very much that the cofactor of fatty liver is very important in driving that pattern with methotrexate.
Certainly, by fibre scanning everyone that's on long-term methotrexate, we certainly see quite a few people with worrying fibrosis, probably cirrhosis, and it is usually they're overweight. But I mean, how many people are overweight, particularly on the steroids and taking alcohol? So it's more than half of them, and quite a few of those are developing fibrosis. So I don't think methotrexate fibrosis has gone away at all. We've had people who've been inappropriately managed too much methotrexate, and they're screening go to transplant and develop HSC.
Rachel. Great questions. I mean, cotrimoxazole is up there on all the lists of drug-induced liver injury, so it's certainly a big player. I haven't seen anything specific about management of those patients, except the more cholestatic ones. More cholestatic type injuries may be USO, for want of anything better. I don't know, Jeff, do you have any other comments?
No, I'd agree with that. And most of the long-term cholestasis slowly get a bit better, but you do hear about these cases. I think they're real.
I've got two ladies who had antibiotics and they became very cholestatic. Gave them Eshone because they were itchy. Tried to stop it, even though I stopped it.
Yeah, no, I think they're
They get worse again. And with biopsy, it doesn't look like PBC. We say, well, are we missing somebody who would have gotten PBC and HD? But actually, everything stays normal and sort of simple Eshone works for you. Okay. I don't know how to define that. I don't know what do you call that.
I get the feeling that perhaps now we're getting these bigger prospective cohorts, a little bit more recognised that there's probably a bigger proportion who do go onto this chronic thing than we realised. Yeah. Oh, John's been his hand up for ages.
Steve always does this. You haven't got more questions? You didn't mention the liver tox database.
Actually, I meant to add that to my slide and forgot.
Cheat sheet that we keep looking
Yes,
at.
yeah.
Think about it, the liver tox database, the online one. Do you find that comprehensive?
I don't really use it.
No, it's another already.
It is a resource. I actually did mean to put their website on the slide and forgot.
I'm skeptical about autoimmune hepatitis in response to statins, but the last time I looked at it was 18 months ago, and I couldn't find a single case report or series that convinced me these weren't bona fide ordinary cases of autoimmune hepatitis and people just happened to be taking statins. Now, there may have been something in the last 18 months.
No, it is still all case reports. It's just people are starting to pull them together and go, oh, there's 5 here and a few here and a few there and more. So,
I mean, these are drugs that take them at 15%.
I had a man recently, actually, who had been on atorvastatin for quite a long time and then came in with another non-STEMI. They doubled their atorvastatin, and then he got referred to me with an ALT of 900 not long after. He had more of an acute liver injury, but he had all positive autoantibodies, and biopsy was would do for autoimmune. We withdrew the drug, but it sort of came down but didn't normalise, so in the end I have immunosuppressed him. But yeah, I agree. This is the problem with the whole literature, though. It's messy. It's very messy.
Yep. Great, thank you, Catherine. I hope you're So last speaker for this session is Jessica Farrell, who's already been introduced this morning. Gave an excellent talk on alcoholic liver disease, and we look forward to hearing you talk about your favourite subject, which is now.
Thanks very much, Stephen, and thanks for staying, and thank you to Catherine for talking about Dilly. Got me out of that, thank God. So one of the problems, there hasn't been a lot of advances in therapy of non-alcoholic steatohepatitis, is people have been rather slow to develop a concept that really relates to reality. And the old concept, based on some work actually from my lab and from Anna May Deal in the 1990s, was there's kind of a two-layered thing, that if you're fat and diabetic, you get fat in the liver and nothing more. But you had to have some magic second hit, and we were talking about cytochrome P452E1 then, and Anna May was talking about TNF, and that caused a second hit. And this is just rubbish. And if people write this in reviews that I'm reviewing now, I just tell them this is more than a decade out of date. It hasn't helped us. TNF is up in people with fatty liver disease without NASH, for example. Antioxidants are not very good for NASH. So the concept now that most people would buy is that the liver injury in NASH is due to a specific lipid which causes liver injury. And it took me a long time to realise this. I realised this in sabbatical in 2005, talking to Sam Lee. It was actually his idea. It's not how much fat's in the liver. That's why MRS as an endpoint is absolute rubbish. It's which fat is in the liver. Okay? So, whoops. So fat where it's not supposed to be, which is in fat cells, can cause insulin resistance, and everybody with NASH has insulin resistance. But if it's the wrong lipid molecule and there's enough of it, it will damage the cell or cause cell death. Apoptosis, necrosis both occur in lipotoxicity. And inflammation occurs by activation of innate immunity, not adaptive immunity, innate immunity. And the response to that's a wound healing response with regeneration and fibrosis, which looks exactly like NASH. This is fat without lipotoxicity, and in simple steatosis, this is liver cell injury, inflammation, and the fibrotic and eventually regenerative wound response, wound healing response that connects NASH to cirrhosis. So what is the lipotoxin? If it's lipotoxicity, wouldn't it be nice to know what the molecule was, and then we could design a therapy aimed at that molecule? And that's exactly what I think we should be doing. And no one set the rules for these, so I don't know if anyone will ever call these Farrell's rules, but to me the simple logic is that this molecule should be higher in NASH livers than NAFLD livers that don't show NASH. And for free fatty acids, that does not apply. It's up in both phenotypes. Also in models that, NASH models that exhibit metabolic syndrome, and a problem in the literature is that most NASH models do not exhibit metabolic syndrome. It would be also nice if we would have an explanation to how the hell it got there, particularly if it was related to the metabolic factors which are insuperably bound to NASH. And we should be able to cause liver cell injury by exposing hepatocytes to the molecule, and we should be able to explain the link to inflammatory recruitment. And I think we've done most of these things now. I don't have time to present all these data. There's a huge amount of data to support the free cholesterol hypothesis, which we believe, and most convincing really is to look at human livers. Those with NASH have a high free cholesterol, those without NASH do not, and no other lipid has that boundary, and this has been nicely reviewed most recently by Musso. So I'm not going through that data now, you'll be relieved to know, but when I came to Canberra, went to Canberra 11 years ago, or actually 6 months before I went, I got an email saying that we've got these fat mice, which aren't supposed to be fat because they're in a non-obese diabetic colony, a NOD mouse, but they're fat. Would you be interested in studying their liver? Because we think we know what's wrong with them. In fact, they have a mutation in the Alstrom gene, and we've actually found that this causes means. And and it's actually a true story. And the first thing about these livers, the blue is free cholesterol. It's fluorescing, they're full of cholesterol. And these are actually cholesterol crystals. Now, there's a very nice story about this, and we have hopefully a paper accepted eventually. The Americans hated it because it exploded some of their dogma, pulled down some of their icons. But George Ionu, actually, who's a colleague of mine in Seattle, he is an American, has actually found the crystals in liver. These are cholesterol crystals just like you find in atheroma. And I don't know whether Catherine remembers, but we used to mutter in our liver clinic that NASH is really just atheroma of the liver. And it possibly is, actually. So I'm not going to talk about that, but that crystals activate the NLRP3 inflammasome, and we have produced the first evidence that a small molecule NLRP3 inhibitor reverses NASH in our model. And I think molecules like that will eventually come into the clinic. So very briefly, here's some of the evidence that cholesterol can cause NASH. These are dietary studies. I won't go through them. But in this study, we increased the amount of cholesterol in the diet from 0 through 0.2% to 2%. You can see the free cholesterol going up in our fat mice, but not in our normal wild-type mice. And this is the ALT showing goes up in parallel. And I could show you lots of other correlations there. This is the reverse correlation. We treated our mice either with atorvastatin, which, as you know, does not reverse NASH, ezetimibe, which also doesn't reverse NASH, or both, which hasn't been done in humans, rather foolishly, because if you block cholesterol synthesis, you upregulate cholesterol transport and reuptake from bile, whereas if you block the uptake pathway, you increase synthesis. So you must do both, and that hasn't been done in humans. So when you lower cholesterol in the liver that way, the ALT goes down over there, J&K activation, everything else goes down as well. So getting rid of that free cholesterol reverses NASH and reverses the associated fibrosis. So this is fibrosis in our vehicle-treated FOS mice, a little bit less with the statin or ezetimibe, but abolished by that combination. So this is all sort of stuff coming up to about 4 years ago. I think the pointer's getting tired. Need to press it for longer. So what I was going to introduce next, I was going to switch from mice to humans, actually, you'll be pleased to know. I get my notes, I can talk without slides. Thanks, Dave. Oh, it's me. I'm pressing the wrong one. What's going on? It's really not working. You can't do that manually? I'll keep on going. I'll just tell you the next bit. So clearly, if free cholesterol accumulates in the liver, there's something wrong with the liver regulation of cholesterol turnover, because that's one of the things the liver does. It takes up HDL cholesterol, it turns free cholesterol into bile acids and secretes them in bile. So it's very important in getting rid of cholesterol. So there must be something wrong. So the concept has arisen that there must be dysregulation, abnormal regulation of hepatic cholesterol homeostasis in NASH. And the FXR agonists obviously are one attempt to try and unravel that and correct it. But the issue arises as to what causes that, and I do need to tell you this, and I can tell you this without showing slides. So one of the things that happens in our mice very early on in life, particularly when they're fed their atherogenic diet, is their serum insulin starts going up. And by the time they've developed NASH, their insulin is very high. In fact, if you do insulin measurements in your patients with NASH, you'll often find they're very high. So NASH is much more likely in pre-diabetes and much more severe than it is in established diabetes, for example. It's all kind of burnt out there. So what Derek Van Rooyen did, is he did primary murine hepatocyte cultures and exposed them to exactly the same insulin concentrations that we knew circulated in our mice at 2 different time points. And when he did that, he upregulated steroid regulatory element binding protein 2, SHREP2, which is the master switch of cholesterol regulation in the liver. And this resulted in increased synthesis of the LDL receptor, an important cholesterol uptake pathway, and it suppressed the bile acid secretory pathway. And these are the sorts of findings that we found in mouse liver and which have been confirmed by Aaron Sanyal in human liver. So with all this going on, we think free cholesterol is accumulating in the liver, and we've actually now done some experiments which are published in which we exposed primary murine hepatocytes to free cholesterol accumulation using LDL cholesterol for uptake of the cholesterol. And in essence, we're able to reproduce the damage, and we were able to show that this was J and K dependent. There we go. We can just go about 5 slides. Keep going. Keep going. About 5 more. Keep going. We'll stop on this one. Yeah, that's excellent. So maybe just skip through that one. So there are the pathways, and we've actually shown that, and it's been published. I'm not going to go through that in much detail. The next slide, I think. One of the concepts, obviously the other main idea about NASH is it's something to do with the microbiome, and it's all to do with bacterial products being absorbed in the intestine. And that may or may not be correct, but one of the things that I've always thought was pretty interesting is that the inflammation in NASH, which is mainly, not exclusively, but mainly macrophages, is actually focused on hepatocytes. And this accumulation of macrophages sometimes in a apparent laurel leaf type structure has been termed crown-like structures. So these crown-like structures of aggregated macrophages, most of which have infiltrated into the liver, are around hepatocytes, which has always suggested to my naive brain that maybe they're being attracted by something that's coming out of the hepatocytes. So I think, and I was originally going to talk about the NLRP3 work, but there's not time to do that. So if you wouldn't mind, maybe this is working again. Oh, it's working again. Okay, we'll skip over that one then. Don't like it much. Okay, back to patients. So as everyone in this room knows, the management of people with non-alcoholic fatty liver disease, whether they've got NASH or even cirrhosis now, starts with lifestyle intervention, but we're not quite sure what we're trying to achieve. We know that most of the time we're doomed to failure. So the next slide, please. So we actually do know now what we're trying to achieve because we've got this excellent data from a randomised controlled trial. Thank you, beautiful. With biopsies before and 1 year after. These people were put on their treadmill and told to eat less, or made to eat less. And we've known for a long time that if you lose some weight, you'll correct ALT and steatosis. And the amount of fat, so these are the people who did and those that didn't, and the amount of fat you needed to lose to correct steatosis is only about, amount of body weight, it's only about 5%. Ballooning is pretty similar. But to correct NASH, you actually needed to lose a little bit more of your body weight. You needed to lose perhaps about 7%. And the whole purpose of these slides, I'm sorry they're such poor quality, is that you can reverse fibrosis. This is fibrosis worsening, this is fibrosis improvement. But to really improve fibrosis substantially, you need to, I know you can't read that, you need to lose at least 10% of your body weight. So we actually, since fibrosis is everything in this disease, we actually now have a gold standard of NASH therapy. So everyone should be trying to do the lifestyle thing. What are we trying to achieve? We're trying to achieve at least 7%, and I think preferably 10% weight reduction to reverse any fibrosis that might be there. And this is certainly what I'm doing with all my patients now. So part of that lifestyle is obviously exercise. Exercise is a good thing, and it's mainly good because it improves insulin sensitivity, and that will drop serum insulin levels, which I showed you mechanistically is probably related to the dysregulation of hepatic cholesterol metabolism. And we now know that you need to probably be at least moderately vigorous, and we need to do more. And the old transsectional study from the NASH CIN network was that the risk of severe fibrosis was actually halved by people that exercise vigorously regularly. So that brings me to the kind of crux of the talk now. So what's the future of NASH treatment? Personal incentives, societal structures, etc., to lose weight. They're just various things that one could brainstorm. Obviously, that's not going to make all that much impact. Or a drug that achieves the same ends. Yay. So, but now we know what those ends are, in my view. It should be a drug that is an insulin sensitizer. It should probably correct that metabolic dysregulation to prevent or reverse hepatic free cholesterol accumulation. So now I think we're starting to get a real target. Nearly 3 years ago, everyone stopped short at the American Liver meetings with this press release. The Flint trial, ursodeoxycholic acid, stopped early. That's pretty unusual for an interim analysis which showed efficacy, based on a highly significant improvement of the endpoint, which shows the old endpoint of an improvement of 2 points or more in the NAFLD activity score with no worsening of fibrosis. Wow! Is this the holy grail of NASH treatment? And I've called this the truth about ursodeoxycholic acid. So when the study was published, that highly significant improvement was absolute trivial reduction in NAS and almost all due to an improvement of steatosis, which is irrelevant. There's no reversal of NASH, and this, by the way, is the new FDA AASLD recommended endpoint, which I strongly endorse. There's trivial effect on fibrosis. A quarter of the patients are itchy. Their HDL fell. Their LDL rose. These are people with NAFLD who have a huge cardiovascular risk. How are you going to use this in people with NAFLD? Well, Intercept, with their people they bought out in the USA and Europe, are now doing a phase 3 trial, which I was invited to be part of it. I would have thought that would be totally unethical and ridiculous. So then recently we read elafibranor, I'll tell you what it is in a moment, induces resolution of NASH without fibrosis worsening. What do you think that means? Once in a blue moon? Half the time? Always? When I read that I think, gee, this is terrific. This must be the holy grail of NASH treatment. Well, first of all, I'll tell you what it is. It's actually a combined PPAR alpha delta agonist, but at the concentrations used, which were between 1 to 2 milligram per kilogram body weight, it has really only PPAR alpha activity in humans. And fibrates, which are pure PPAR alpha agonists, have almost no efficacy in NASH. So you wouldn't really expect it to work. And of course it doesn't work. So by intention to treat, there's absolutely no difference in the primary endpoint, which was the old one. The post hoc analysis, and I think this is reasonable to look at this, but look at the difference. 19% versus 12%. This is the treatment of hepatitis C in 1989. This is ridiculous. It is good in the metabolic improvements. It doesn't make things worse. So I think this is a real effect, but it's incredibly weak and it's probably dose dependent. And it's probably because we're not getting any PPAR delta effect out of elafibranor. So now I want to get back to our mice again. This was presented in a diet. They're given that for 20 odd weeks. They're given either drug or vehicle by gavage, and we measure some endpoints. Now, first of all, in normal mice, there's a little bit of effect on weight reduction, but in the fat mice, any effect is really trivial and is not actually significant. So it's not a very powerful group of agents. The ALT drops, and there's a significant effect on ALT. The serum lipids are normalised. Triglycerides very low, but even the high cholesterol in phosphorus mice is normalised. And we're more interested in fats in the liver, so the ordinary fat, neutral lipids, most of which is triglyceride, are normalised by compound. So are total fatty acids. And total cholesterol, most cholesterol is esterified. But what we're most interested in is free cholesterol is normalised by this compound. This was the first drug we've tried, apart from the combination of statin and ezetimibe, which actually corrects free cholesterol. It also corrects diacylglyceride, which are potential pro-inflammatory agents. And if you believe in saturated fatty acids, and I don't think they're important, it also corrects all of them. So it corrects pretty much all the candidate lipotoxins in NASH, at least in our mouse. These are wild-type mice treated with the drug. You can see all the fat's gone. These are the FOS mice with NASH. Again, major improvement. In fact, when we treat our FOS mice with vehicle, 8 out of 8 developed NASH. And when we treated them with MBX 8025, none of them had NASH. They all had simple steatosis. The NAS score fell from nearly 7 down to 3. I'm running out of time. I think there's improvement of inflammation. And most importantly, once again, this is the fibrosis in the vehicle-treated mice and a substantial reduction in serous red collagen-1 densitometry when we treat them with the MBX 8025. So this highly selective PPAR delta agonist has very potent effects at reversing hepatic lipotoxicity through metabolic improvements, providing first proof of principle that such agents can truly reverse NASH and related liver fibrosis. So hopefully we've left behind now the era of empirical therapy, therapy based on flawed concepts, therapy based on flawed endpoints like ALT, and over-extrapolation of borderline efficacy. I think the future now is because we've got this strong data from weight loss studies that it can resolve NASH, that resolution of NASH can also resolve fibrosis. So that's an important concept to have. Newer agents that combat lipid partitioning and lipotoxicity, and particularly selective PPAR modulators such as PPAR delta agonists, maybe the dual agonists, are likely to be very effective agents in NASH when we have potent ones in humans. And I haven't discussed it today, but targeting inflammation is also becoming more logical. The anti-CCR2/5 agent, which I can't pronounce, Senicriviric, the Centaur study, also showed a reduction of fibrosis, but without a reversal of NASH. And as I said, our experimental data with the anti-NLRP3 agents. So I think we're entering an exciting era at last. It'll be a few more years before we have these drugs in the clinic, but I don't think we have to be pessimistic and feel that we're forever spending 3/4 of our liver clinic telling people to lose weight. Thank you very much for your attention.
Thanks, Jeff, for a great talk delivered under some technical duress. Apologies for that. That's a very bright laser now with that new battery. I'll point that out with planes, so we'll be on the same list as Atom and trouble with airport security. Now, it has been pointed out by John that I've been hogging the questions, and I see you've got your hand up, John, so what is it,
Atorvastatin and ezetimibe helped your fat optimize mouse to lose its free cholesterol from the liver. Has there been a human trial?
No. And we proposed to one of the companies that made these agents to do a trial, and they were going to sponsor one international study in anything to do with their drugs, and we came second. So I don't know if that study will ever be done. George Iono and I have talked about it. I really think it would work. It's very logical. The combinations used now for statin, relatively refractory hypercholesterolemia in people with cardiac events, but I just don't know if anyone's going to do the study, which is very sad because I actually think it would work. As you know, either agent used alone is really pretty pathetic. Yeah. Sorry, Jeff.
The crown structures in the liver, I memory they're also seen in adipose around the
Yeah, in fat.
the fat.
Yeah.
Is that correct?
Yeah, absolutely.
It's in perfect.
Yeah. And we do quite a lot of, in fact, Faro's main subject of his thesis was adipose inflammation and its relation to NASH, and we don't have there's a lot of questions about that, Jeff, we haven't solved yet. And I know Isabelle Leclerc, you remember Isabelle quite well, and we still communicate a lot now. She's a very independent investigator, leading one in Belgium. But I think we both thought that maybe the inflammation starts in the adipose and eventually migrates to the liver, and that idea doesn't really hold up very well. They don't go terribly well in parallel, but we're not sure what's going on there. It's again probably a manifestation of innate immunity and damage to fat cells in that case. I hope there are no shareholders in Intercept here. I just find it mind-blowing, and when I look at the ASLD program, everything's supported by Intercept. Sorry.
So my last question was, are you going to then allow the mice to get NASH
Yeah.
and then try and treat them?
Yeah. That's a really good point, Jeff, because, you know, even though I'm waxing lyrical about the fibrosis reversal, to be really honest, it's not all that severe in the worst ones. They certainly don't have cirrhosis and they don't have stage 3. So we are doing a longer-term experiment now, both with our anti-NLRP3 agent, including a novel one, which is patented and could potentially go into humans. MCC 950 won't go into humans, and also with the PPAR delta agonist. So we're taking it an extra, 3 or 4 months, and we hope that we'll be able to show more scientifically that we actually truly reverse fibrosis when it's more severe.
One last question.
Are you saying that the cholesterol crystal itself
Yes.
is triggering an inflammatory response?
Yes.
Like uric acid?
Yes. Exactly.
Because they look incredibly inert.
They're not.
They're not.
No. You actually, because when you add them to Kupffer cells in very low concentration or any sort of macrophage, these cells, spit out interleukin-1 beta like there's no tomorrow.
Do they ingest the crystal?
They do, yeah. There's some very important work that's being done, and it's not all finished yet. We're not doing this, on actually how hepatocytes would, how crystals would form in hepatocytes, what's the role of the endosome and lysosomes, etc. and what actually happens when the liver, what we think is the liver cell dies. Probably doesn't die from the crystals, it probably dies from free cholesterol and mitochondrial injury. But once it's dead, of course, if it's a necrotic cell death or another form of disorganised cell death, it will liberate those crystals. You've got macrophages everywhere because that's how the liver's made, Kupffer cells there, and they will see these, they do engulf these crystals and will become activated.
Great. Now, I think we better call things to a halt this afternoon tea time. We're back in here at 3:30. I'd like to thank all our speakers for excellent talks. You can ask your question.
It's about a little bit of incentivizing patients, like getting them to use.
Hello, how are you?
Talk to them about
phone calls as I'm driving. Oh, no, I'm driving.
Sorry about the slides.
No, that's okay.
My name's just most of the IT guy runs out. And the slides aren't visually.
That's actually quite interesting. Some people get sick of slides. I just couldn't.
Master
I wanted to
carry
check
on.
that that's actually where I was going to go into the stuff.
It's just one of the things that you did there, because actually I always have a copy of my slides printed out in my bag, just, and I'm like, am I just possessive about actually seeing that
Well,
you there?
and the gaps were, the one thing that I don't know yet is
So words
more than
that
half
are-
is my cohort. So it does look like exciting times. Really does that for us. I think they mobilise the fibre scans are not getting worse, so I think we're probably safe as we sit there. But I don't know what's happening.
Most people, if they're gonna whip
I don't
that
know
they
if
have
it's
something for
lifestyle
Nash,
information.
yeah, like, look at
Actually,
it.
I would say this is
Hope
from
that
next
that's the case, but
So if I send it to Rick, for example,
if theoretically, like, until I have more, it's like, it's
And I
not
think
good.
we're YouTube.
Yeah, they're all laughing.
And the phone in as well is a local. So,
I know it's your
When are we
comments on
doing
this,
that, by the
because
way?
I've looked at it.
Okay, so we should,
You make the whole number profile worse. I find it quite interesting, because I've done those studies either. I've been turning down a lot of niche ones.
so and how do they, give 3 prizes, 2 prizes, 1 prize? Okay, we can do that.
Coffee, cake, Jeff, the 3 of us are judging the liver papers. Me? Yes, okay. Somehow I got thrown in the newspaper. That was in an email a few days ago, and apparently we're supposed to decide amongst ourselves how to decide the fees.
I think I ran out of data on my phone, watching those videos. You talking to that other technology, just like, okay.
Check, check, 1, 2. Check, check, 1, 2. Check, check. Check, check. 1, 2, 3, 4. Check. Check, 1, 2. Check, check.
Added on 20 GB. That's given a normal play. And you use the,
That's the wrong one.
that was one of the ones I was pretty sure that was playing before, but yes, that's. I mean, that's.
Is one of the USBs plugged into your Mac?
No,
Oh, okay, sweet. Just need a Logi. I'll use the Logitech one.
Just on this one here, I'll tell you that we have to do, I just need you to click on the video to play it.
Okay, so once you, when you first got on the job,
No, but all of them play except this one, right
Check 1 2. Check 1 2.